Minimal residual disease detection, or MRD detection, is something we have worked on for a long time. I think I worked on that for almost 8 years now, and I've given many talks on it. Finally, we have come to a point when we now started talking about how we can use it in the clinic every day. We actually have used it in clinic for almost 2 years where I work. We are using it to go up and down in the intensity of therapy for our patients. So what I will talk about today here at this meeting is different ways of doing the MRD testing. For many years we used flow cytometry. We are now moving into more advanced molecular testings, and we have also proteomic testing approaches we are developing. You can test MRD in the blood even. This is still research, but I think we are soon getting there. Anyway, so using these approaches, I show that we can measure the depth of response, and then we can kind of scale back. We are even using it to determine whether a patient could go for a transplantation or not. So these are pretty bold moves. The field is moving faster than ever. I think that in 6 months, big pieces have changed, and it just keeps on happening every 6 months. So it's almost hard to catch up. When it comes to MRD, there are now studies both in the newly diagnosed setting and in the relapse setting showing that patients who obtain an MRD negative state after combination therapy, whatever that therapy is, they seem to have about the same outcome in terms of progression-free and maybe also overall survival. So that kind of raises the question whether MRD negativity is more important than therapy. And that's exactly what I'm talking about here today. If you give a combination therapy with modern drugs and the patient turns into MRD negative, could you then go forward with some type of maintenance therapy? And you could maybe, for example, keep the cells that you have collected for a transplantation, keep those cells in the freezer instead of throwing a transplant on every patient. So there are still no phase 3 data to answer the question formally in a randomized fashion, which is the right way to go. But I do think that a lot of the preliminary data we have in different settings suggests that MRD is probably more important than the type of therapy given in order to obtain MRD negativity. I think in a simple way, you could summarize and say MRD has now come to a point where you actually can use it in the clinic. If you have the ability to test for MRD negativity with a reliable test, and the clinician really needs to make sure how that is done in the laboratory because it still varies a lot. But if the clinician has access to that, if you treat the patient, you probably can use that to step back in the intensity of the treatment for the patient going forward. If you're not going to check, you probably have to give every patient the same therapy, which is the way we have treated patients in the past. So it's really an opportunity to individualize or tailor therapy for patients. So it's a kind of a complicated process because when you start off, for example, with a newly diagnosed patient, you certainly don't know how deep this patient is going to respond to the therapy you are now planning on giving. You don't know that until you have given the therapy. So you're kind of outlining a plan day one. You say that we're going to give you this many tentative cycles of therapy, and we will check every cycle, and at this time point we will evaluate for MRD status. If you are negative, the tentative plan will be to go forward in a certain direction. If you're positive, it will be to go in the other direction. But we will have to start therapy and we have to check, and when we come to this time point, that's when we will make a decision.